This is Chapter 8 of Weber and Kelly text. The chapter discusses the general survey and vital signs. So the general survey begins when you first see the patient before you even necessarily say anything. You're going to notice such things as her or his physical development and general build, and get a impression of their apparent gender and whether they're developed for the way that they've had their sexual development as appropriate for age and gender. Their apparent age, and you're going to have to compare that with their chronological age. They could in many cases look a little older than their stated age. General skin condition and color, and is their dress and hygiene, and posture and gait. And many times you're going to maybe see something, well, there's something a little bit wrong, but I can't define exactly what it is. And you pay attention to that, and that can give you a clue as to which specific systems to assess more deeply later on. You'll also, in the general survey, you'll get an impression of their level of consciousness, and if your first impression is okay, then maybe you wouldn't need to do a complete neuro assessment. But if you get a first impression that for example that there is something wrong with their level of consciousness, then you would want to explore the mental status as we mentioned in chapter 6. You would do all those things, all those tests very thoroughly. Behavior, body movement, and affect. Affect meaning their emotional expression. Facial expression, and then speech. And finally, vital signs. That's what goes into the general survey. So this really is accomplished very quickly. It sounds like a lot, but this is basically just your first impression of the client, and then your vital signs. Abnormalities of vital signs usually indicate that something is wrong. Now, there are exceptions. We have, for example, people that have bradycardia and absolutely nothing is wrong. They just have very conditioned hearts. So there can be some abnormalities that don't indicate something is wrong, but when you find an abnormality, why you need to investigate it, and why is this? Is this something that the patient usually has, or is this a new thing that's indicating something wrong? The traditional vital signs are temperature, pulse, respiration, and blood pressure. In recent years, some people have added pain to that, although pain is not really something you can directly measure like those other things are. Vital signs are usually taken early in the exam for several reasons. For one thing, they can point you to what may be wrong. They can carry a lot of information in one little piece of data that's quickly obtained. For another reason is that you want to do familiar things first, because most clients will be familiar with vital signs, so you want to do familiar things to set them at ease with you before you proceed to more invasive or less familiar things. The vital signs are going to give you information specifically about the cardiovascular system, but also about your neurological system, perhaps, maybe peripheral vascular system and respiratory system, and they can certainly give you information about other systems as well. But they're going to be particularly useful for those systems that I just mentioned. Measure the temperature first, and the reason for that is depending on what method you use, it may take a minute or two, and that kind of settles the patient down and keeps them still, and you want to keep them still and settled for a minute or so before you do pulse, probably more than a minute or two, but you really want to get them still and keep them still and at ease before you do the pulse, respirations, and blood pressures. There's this idea of a core body temperature, which would be the body temperature if we just stuck a probe into your body core, into your, we opened your skin and put it into your body and had a temperature probe in there. Why, then the normal temperature in your body core would be between 36.5 and 37.7. Less than that would be considered hypothermia. More than that would be considered hyperthermia. And the Fahrenheit equivalents for those measures are 96.0 to 99.9. I want you to learn both Fahrenheit and centigrade measures because you are probably going to have to use both during your career. Some hospitals use one, some use the other, and some hospitals even use both systems at different times. So there's really no alternative but to learn both. You could convert them, and you certainly, like maybe if you're more familiar with it in one system, you might want to convert to the other system. I'm not going to teach you the conversion factors in here. You can easily find those or conversion factors elsewhere. Temperature is usually lowest in the early morning and highest in the late afternoon. And it's also influenced heavily by things like exercise, stress, or ovulation, and also hypoglycemia, hypothyroidism, and starvation. So they can push you either to the hypothermia or hyperthermia side. Hyperthermia is, generally speaking, temperature greater than 38 or 100 Fahrenheit. And one thing that can cause it, and that we probably think most often, is viral or bacterial infections. But there are other things that can cause it as well. It doesn't always indicate an infection. For example, a malignant tumor can cause it. Trauma, particularly trauma to the hypothalamus, can cause hyperthermia. And blood, endocrine, and immune disorders can also cause hyperthermia. The pulse is produced by the heart beating, and each heartbeat, blood is forcefully pumped out and courses through the aorta and ultimately through all the arteries. And so those forceful ejections produce a pulse wave. There are many different sites where you can palpate a pulse, and we'll see all of those in chapter 22. For right now, we're going to focus on the radial site, and that's on the thumb side of your wrist. When you assess a pulse, you're going to assess several things. First, the rate, how many beats per minute, but also the rhythm. Are those beats equally spaced or are they irregular? The amplitude of the pulse, and that's measured on a scale of 0 to 3, where 0 means you can't feel it at all. 1 plus means that you can feel it, but it's very easy to obliterate. If you put a little pressure on it, it goes away. 2 plus means that it can be obliterated with moderate pressure, and 3 plus means either you can't obliterate it or it takes extreme pressure to obliterate it. And the 3 plus is also known as a bounding pulse. Contour refers to the pattern of that wave, so you should have like a spike, initial spike, where it rapidly gets to its maximum, and then the decrease of the pulse wave is a little slower than that first initial spike. And you also want to assess the elasticity of the artery. Does the artery feel pliable, like you can easily move it, or is it rigid and firm? For respirations, you want to try to observe them without alerting the client, and there are various ways to do this. One way would be if you're feeling a radial pulse, when you would feel it and count it, and then just keep your fingers there, but you don't even pay attention to the pulse anymore. Now you're looking at the person's chest, and the person thinks you're still checking their pulse because your fingers are there, but you're actually counting their respirations now. Another way would be if you're listening with a stethoscope at the chest for the apical pulse, which we'll talk about a little later. Why, then you could just leave your stethoscope there and do the same thing. So for respirations, you're going to assess rate, rhythm, and depth. Again, rate being how many respirations there are in a minute. Rhythm is whether they're occurring at regular intervals or irregularly. And depth meaning, are they breathing deeply, shallowly, intermediately? Then blood pressure is the pressure on the arterial walls, where when that it's the pressure on the inside basically of those arterial walls, and it's measured in millimeters of mercury, where it's a pressure sufficient to raise that mercury column 1 millimeter. Is each one. And on the typical sphygmomanometer, which is the instrument we use, each of the little marks is going to count for 2 millimeters of mercury. So be aware of that. Like if it's 1 mark above 110, that's not 111, that's 112. That's a point that some people frequently miss when they're first beginning. And they'll tell me, oh, it's 113, and I'm saying, how on earth did you get 113? And they, well, here, and they point 3 marks above the 110, and I'm saying, oh no, that's 116. Systole systole begins with ventricular contraction, and that's the high point of the pressure. When that initial spike occurs, the high point of that spike is going to be the systolic blood pressure. Diastolic blood pressure is the low point, and that occurs when the atria are filling, and basically the you aren't feeling, if you were feeling on the that radial artery, you would feel a pulsation, and that would be the time for systole, and then diastole would be the time when you don't feel anything. Blood pressure is affected by cardiac output, and cardiac output is stroke volume times the minute rate. So So that would be like each uh, that would be your cardiac output. Arterial distensibility, how elastic those arteries actually are. If they're very rigid, why then they're not going to be able to expand to accommodate the pressure, so the pressure is going to go up. So yeah, cardiac output really should be stroke volume. For each stroke of the heart, you're going to put out a certain amount of blood. We can't measure that directly unless we're in an ICU or a cath lab or somewhere where we have special instruments, but we know that that is affecting our blood pressure. So the stroke volume, how much they're putting out for each with each beat. Arterial distensibility, how compliant those arterial walls are. Do they expand to accommodate the volume? Blood volume. If you have increase in blood volume, you're going to have an increase in pressure. And blood velocity. How fast is the blood flowing? And blood viscosity. How thick is the blood and how resistant is it? So any of those things can affect blood pressure, or do not can, they do affect blood pressure. Other things that affect your blood pressure would be time of day. If you're using any caffeine, nicotine, alcohol, etc. Exercise, or your general activity, what are you doing? And even your body position, emotions, pain, and your body temperature, and the temperature in the room as well. Pulse pressure is the difference between systolic and diastolic pressure. So if you have a blood pressure of 150 over 100, pulse pressure is 50. If you have 140 over 100, pulse pressure is 40. And this reflects stroke volume. It's not, you can't put a number on the stroke volume, but you know that if pulse pressure is increasing, why then stroke volume is increasing. If pulse pressure decreases, why then stroke volume is decreasing. So that can be important when you're assessing patients with heart failure or things like that. If you have something like a very small pulse pressure, like say 130 over 100, why then, oh, this person has a problem with their cardiac output. Their stroke volume is not as much as it should be. And you'd mainly be looking for changes, like if it was 150 over 100 and now it's 130 over 100, that would be a bad sign. Variations in blood pressure. Now in the normal individual, when they stand up, the pressure is going to go slightly higher, not much. You probably, if you took it, maybe it might only go up, say, 4 millimeters of mercury or something like that. It wouldn't go up much, but you would notice a slight rise. And this is just the body has various systems to compensate and try to maintain homeostasis. And so in order to compensate for the gravity, the body will slightly increase our blood pressure. The reclining person will be more relaxed, and they'll normally have a little bit slightly lower blood pressure. But there are situations where this does not hold true at all. If you have hypovolemia, a hypovolemia occurring, meaning you have less fluid than you should, less blood than you should, less fluid, why then when you stand up, that blood pressure could drop precipitously. Like you might go from 140 over 80 to 120 over 60 or even lower. And what's likely to happen as well with a patient like that is that person probably will get dizzy and they may even pass out and fall when they stand up. Pain. Pain is very important to assess for several reasons. It's important for comprehensive care planning. It's probably your patient's biggest priority at the moment. Your biggest priority might be their blood pressure or their heart rate or something like that, but their biggest priority is likely to be pain if they're experiencing it. You would want to do cold spa on a pain that they complain about, and at a minimum get location, quality of the pain, intensity, duration, and aggravating or alleviating factors. There are various pain measurement tools that we use, and those will be described in Chapter 9. In the health history, as always, you would begin with biographical data. And then present health concern. It could be just a routine physical, which a wellness visit they wouldn't necessarily have a present health concern, but if they do, then you'd go to that. Then you'd ask about recent fevers. If they had a fever at present or if they'd had any fevers recently. Ask about alterations in heartbeat that they notice, whether it be that they're noticing skipped beats or if they're noticing really pounding heartbeats or palpitations, heartbeats where you feel your heart beating, various things like that. And if they have had any difficulty breathing, and if so, is it at rest or on exertion, or under what circumstances do they have difficulty breathing? What is the person's usual blood pressure? Whether or not they know that is going to tell you a lot about how engaged they are with their health. And then when and where did they have their blood pressure checked last time? That again is going to tell you how well they're doing with health maintenance. Are they aware of any heartbeat issues, that whether it's unusually fast or usually slow or whatever? Many times this can be caused, a slow one particularly, can be caused by medications, but it could also be caused just by good conditioning, like somebody that does distance running a lot of times will develop a slow heart rate, and there's nothing at all pathological about it. Fast heartbeat could be either continuously fast or it could be intermittent, like maybe they just have runs of tachycardia but they're normally not fast, and they occasionally have runs of tachycardia. Then also ask about any medications, and of course allergies. Ask at some point in all of our assessments, we want to ask about allergies. Then as far as family history, you would want to know about heart disease, any diabetes, thyroid disease, lung disease, high blood pressure, cancer. And then as far as lifestyle and health practices, ask about educational background and employment or occupation. Their occupation may put them at risk for certain things, depending on their, like somebody that is in a really high-powered job, like maybe a lawyer, might be subject to a lot of stress. Somebody that works construction would be exposed to a lot of environmental problems, to heat in the summer, to cold in the winter, all kinds of things that they would be exposed to. So employment and occupation, somebody that is not employed would have limited resources, maybe not have insurance, and would be at risk for other things. Is the person satisfied with his or her life? And that could give clues to stress. How often do they seek health care? Another question that would help us with engagement with health care. And of course, tobacco, alcohol, drugs, those are risk factors for just about any system. Are they on any special diets? And do they get regular exercise or not? Physical development and build, that's the first item in your general survey. And there's a wide variety of types that are normal, and chapter 13 will talk about specific body types. But you may see something like, no, that's not within the normal body types, and there's like things like gigantism, dwarfism, Marfan syndrome, various things like that. The book at the end of the chapter has pictures of those various things. To help to quantify it a little bit, you can compare their arm span to the height, where you have them, you measure the whole arm span with both of their arms out, stretched out as far as possible, and that should be about equal to their height. And then you should also can also compare the distance from the crown of the head to the symphysis pubis, and that should be about equal to the distance from the symphysis pubis to the sole of the foot. So those are ways of, rather than saying, well, their body type looks a little bit strange, this way you can quantify it a little more. Gender and sexual development. Well, this can be a minefield in that some people may not identify with the gender they were born with, or they may not identify with any gender at all. There are people nowadays that don't have a gender. There are also situations where gender is ambiguous from the chromosome standpoint, where people that are born with apparently female but are actually male, and vice versa. And then, as well as these, the secondary sexual characteristics may not be developed. You may have situations where puberty is delayed, and so even though they're 16 or 17, they're underdeveloped. And so there are situations like that. Now, these would call for evaluation beyond what you would do in one assessment. They would probably in most cases they've had a lot of evaluation already, so that would be something you would explore in their past medical history or past history, what kinds of evaluations have been done. And you're not likely, unless you're dealing with pediatric population, you're not likely to come upon a case like this where they've not had any assessment or evaluation done at all yet. Then apparent age versus chronological age. Various stressors can make a person look older. Tobacco and alcohol are two factors, but also things like just being exposed to a lot of environmental problems, or having lived a hard life can make you look older than your apparent age. I mean, you're older than your chronological age. And then the other thing is that your developmental level may not correspond with your age, and that's usually something that is less than maybe your a young adult, but you're still developmentally, you're maybe still dealing with teenager type uh, issues. General skin condition and color you'd observe for pallor, for flushed skin, for jaundice, perhaps cyanosis or ashen gray skin. And there are many more things to say about skin. We'll see that in chapter 14. Temperature. So we already talked about core temperature. And depending on how you take the temperature, different values are going to be normal. So these are the values for all the ways we commonly take temperatures. We can do tympanic, where we put a probe into your outer ear, and that's fairly close to core temperature, as is the rectal. The rectal temperature and temporal temperatures are fairly close to core temperature. The temporal temperature probes we use at the Smart Lab for some reason always give low values. I don't know why that is, but the values they give us are lower than that. The two most commonly used ones, well, temporal is pretty commonly used because it's quick and easy to do. But the two fairly common ones are oral, and then if you can't, for some reason you can't get a temporal one, your methods you'll be using would probably be oral or axillary. And as you can see, those are going to be lower, a little lower than your other methods. So keep that in mind. Some people will say take an axillary temperature and say, oh, well, you know, the axillary is usually about 1 degree lower than the oral, so I'll just add a degree to it when I chart. And that's the wrong thing to do. You should chart the number you get, but also chart the method that you use to get it. So don't think, well, I got this rectally, so I'm going to subtract a degree, or I got this one orally, so, well, orally I'll just leave it as is. But yeah, just leave the temperature, give the number as you got it, and then state somewhere in your charting how you got it. For pulse checks, you always want to use your fingers, not your thumb, and the reason for that is because your own radial pulse goes down into your thumb, and if you press in the wrong way, you can be actually feeling your own pulse in your thumb, and you can confuse that with the beats from the patient and get an inaccurate count. So use the pads of the two middle fingers to do that pulse check. And if the pulse is regular, you only need to go 30 seconds and then you can double it. But if it's irregular, then go for a full minute. Normal pulse is anywhere from 60 to 100. Less than 60 is called bradycardia. More than 100 is called tachycardia. So, as we said, the rhythm should be regular, and depending on how attuned you are to rhythms, it may be difficult to it may be difficult to detect an irregularity. It may take some practice before you can really detect it. If you have an irregularity, it can be irregularly irregular or regularly irregular. And by regularly irregular, we mean that, say, every third beat is dropped, but it's the same amount of time. Like don't dun, 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 dun. But irregular would mean that uh, dun, 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 like that. There's not any pattern to it. Uh, if it's irregular, you would want to auscultate the apical pulse, and we'll teach you more about doing that in when we get to the heart. But you basically go to the fifth intercostal space on the midclavicular line, which is basically just below the nipple, and it's where when you were in kindergarten and your teacher told you feel your heartbeat, that's where you can feel it, and you might be able to still feel it. Some adults can, some can't. So you might be able to feel it, and that's where you would auscultate to detect the apical pulse. And at the same time you're listening, you'd also be checking the radial pulse and see if any of those beats, like you may have some apical beats that don't translate into a radial pulse, so we would call those dropped beats. So that's the point there. You'd want to auscultate and see if there are any radial beats that are dropped. Another thing, you would want to assess amplitude, meaning remember that's +1, +2, or +3, or well, it could be 0 too if you didn't feel it at all. But the +1 is easily obliterated. You just push it a little bit and it goes away. +2 is obliterates with moderate pressure. And +3 either doesn't obliterate or it takes a lot of pressure to obliterate it. Then contour is just that pattern of the pulsation itself. Like it should suddenly go up and then go down a little more slowly. Then elasticity of the arteries refers to, are those arteries, like, are they elastic, or are they rigid? Then as far as respirations, normally we observe chest rise. Sometimes, particularly in an unconscious patient, you could just put your hand over their chest and feel chest rise, or you could even put a stethoscope over say the trachea or over somewhere and listen for how many breath sounds. But that wouldn't work too well with a conscious patient because they're going to modify your breathing if they know you're watching them. If the respiration is regular, you can go for 30 seconds and multiply by 2. But if it's irregular, why then you'd have to go for a full minute. The depth of the respiration is also, is it deep, is it shallow, and then is the chest expansion bilaterally equal, or is it more on one side than the other? Then blood pressure. You measure the dominant arm first, like if they're right-handed, measure their right arm first. But take both arms when you're measuring for the first time, and then from then on use the arm that has the higher reading. Now you can't always do that. Like they may have restrictions. Some patients may have an AV shunt for kidney dialysis. You can't take a blood pressure at all on that arm. It's contraindicated. Some patients may have had a radical mastectomy, and you can't take a blood pressure on that arm. Some patients have a problem with both arms that you can't take blood pressures or on, and so then you're kind of in a bind. You have to take it in some other body part. but for our purposes right now, we'll assume you can take it in the person's arms. So you would take it the first time in their dominant arm, then after that use whichever arm you got the higher reading for. Normal is less than 120 systolic and less than 80 diastolic. The book has various categories of pre-hypertension. That has the latest W&KCh8 category eliminates the idea of pre-hypertension. Now they are saying normal is less than 120 over 80. Elevated, they're calling anything 120 to 129 or to be elevated. And then if the diastolic has to be less than 80 as well. If the diastolic was over 80, or if the systolic is 130 to 139, why then that's stage 1 hypertension. Stage 2 systolic of 140, or if the diastolic is at least 90. And then a hypertensive crisis would be a systolic over 180 or diastolic over 120. So these categories, I imagine by the time you graduate, they'll be changed again. And if not by the time you graduate, certainly by the time you've been in practice a year or two. So the categories will be changing, the recommendations will be changing, but this is what we'll use for now. And even as I am recording this, why by the time we get to the class and all that, it may have changed yet again, but you do have to stop at some point. Steps for measuring blood pressure, and we'll go over this in more detail in your lab. But first off, prepare the patient. You get any clothing out of the way on their upper arm. Some people have all kinds of sweaters and all kinds of stuff on all the time, and so that may be more or less difficult depending on the person. Then you'd want to determine the cuff size, and the bladder is that rubber part inside the cuff. You can feel it has a length and a width, and the width should be about 40% of the distance around the upper arm, and the length of the bladder should be about 80% of the distance around that upper arm. So then when you've determined that you have the correct cuff size, why you center the bladder around the brachial artery. Then you make sure that it's on securely. Then you palpate either a brachial or radial pulse and keep your fingers on that pulse. Start pumping up the cuff until you feel that the pulse disappears, and then keep going. Don't move your finger. Keep going 20 to 30 millimeters more. Slowly release air, and then when the pulse reappears, it should be the same number as when it disappeared. If not, why you've probably done something wrong. But assuming it's the same, let's say that's 120. So that is your systolic that you palpated. Then you're going to put the diaphragm of the stethoscope over the brachial artery, and you want to have it firmly pressed, not so much as to occlude the pulse, but you want it pressed firmly enough to where the diaphragm is all of the diaphragm is touching skin. Then you pump it back up to about 20 or 30 more than that systolic that you just palpated. Slowly release the air. and then notice when you begin to hear beats. And if you read the section about the Korsakoff sounds, you'll see there are 5 different sounds. So the tone of those sounds and the loudness of those sounds is going to change, and it could change more than once. So be careful, because you might, especially beginners, you frequently will mistake that change in tone. They think it's stopped. So, and then what's even worse is sometimes it actually does stop for maybe a few millimeters of mercury, but then it reappears. So you want to make sure that it's actually stopped. But whatever the number where you stop hearing a beat is now a diastolic. The diastolic. So the 2 numbers you are concerned with are the number where you begin to hear the beats and the number where you don't hear them anymore. And so you note those 2 numbers, and that is your blood pressure. Some of the factors that affect blood pressure we mentioned earlier: room temperature, activity, alcohol, tobacco, caffeine, muscle tension, bladder, if their bladder is distended, arm position, body position, stress, and even noise, even the nurse or people talking, or noise in the room. So after we've done our general survey and our vital signs, we may have some nursing diagnoses. We may have one might be readiness for enhanced health management. Maybe as we were talking to the person, she says, oh, you know, I really need to watch my blood pressure more. Teach me how to do this. Well, that's not a problem, but it is a nursing diagnosis. We say, well, you know, she's interested in learning how to manage her blood pressure more. So we'd give her a diagnosis: readiness for enhanced health management, related to her expression of interest in blood pressure management. Or we could have risk for imbalanced body temperature, related to, say, exposure to extreme temperatures. Say we learn that the guy is working construction, and he works throughout the year in construction, and he mentions that he got frostbite once, and we so that would be risk for we would diagnose him with risk for imbalanced body temperature related to occupation and extreme temperature exposure. Or perhaps we discover that our patient is one of those that's not normal. When she stands up, her blood pressure drops precipitously, and she even talks about being dizzy. We might diagnose her with risk for falls related to orthostatic hypotension. Some actual those were the health promotion and risk diagnoses. Now here's some actual ones. Maybe impaired verbal communication related to developmental delay, as evidenced by childlike speech. I'm thinking of, say, someone that a person with a developmental disorder that has trouble speaking at all, or speaks only in very childlike terms. Or maybe impaired walking related to unequal length of limbs, as evidenced by shuffling, not shuffling gait, as evidenced by abnormal gait. Or let's say the patient complained of pain, and we assessed their pain as 9, and they describe their pain as being 9 out of 10, and that it's a headache, acute pain related to unknown factor as evidenced by patient report. Or perhaps the patient, remember part of our general survey is hygiene and dress. Let's say the patient was in dirty clothes, had trouble unbuttoning his shirt, self-care deficit related to arthritis or arthritis in hands as evidenced by inability to manage buttons. Now, you might be able to change the wording and make the wording of those things a little more elegant. I'm just spouting things off out of the top of my head here. Many of the problems we detect with vital signs are going to be collaborative problems. Some of them might be emergency referrals, but remember the difference between a collaborative problem and a referral is that in a collaborative problem the nurse is still going to play a role, but the nurse needs input from another professional, where with a referral the nurse is basically handing the problem off to and not anticipating being involved in continuing to be involved. So risk for complications of hypertension. We discover that the person has a blood pressure that's say 160 over 110. We can't handle this alone, but we expect to continue to work with the patient. Risk for complications of hypotension, basically just the other extreme. Risk for complications of dysrhythmias. Certainly there are various dysrhythmias. Some of them are life-threatening, some of them immediately life-threatening, some of them are not. And when you get to the critical care class in Senior 1, well, you'll learn a little more about that. Risk of complications for hyperthermia, and then also risk of complications for hypothermia. And then, of course, tachycardia and bradycardia, that's the heart rate is fast or the heart rate is slow. And then risk of complications for dyspnea or for hypoxemia. Referrals. Well, I think the difference is going to be if you get findings that are like emergent, that you think that the patient is going to and tachycardia, I mean, we could have risk of complications for tachycardia that we're going to continue to manage, but if that person's heart rate is maybe 180 or something and it's an adult, why then that's not something that that person's going to need some interventions. We may eventually be dealing with them again, but or taking care of them again, but we're going to need to do an emergency referral. Or risk of complications for hypertensive crisis. Again, we may, once they're stabilized, we may continue to monitor them, and well, we may continue to monitor them, but it also could be a referral situation where we're handing them off. And then acute hypotension too. That could be like, we could have hypotension and maybe call and get orders. Well, try a bolus, and then we try the bolus, and that still doesn't a fluid bolus, that still doesn't raise the blood pressure. But then we could also get hypotension that's so severe we think that the patient is about to code. So then we would maybe want to call a rapid response and basically refer that client to the rapid response team.